My name is Anna Lee, and I'm from Memorial Sloan Kettering Cancer Center in New York. I want to thank the organizers for the opportunity to share our work in the PRESS program. I will be presenting our study titled Changes in Cancer Mortality Rates after the adoption of the Affordable Care Act. Next slide. As a result of congressional approval of the Affordable Care Act, also known as Obamacare, in 2010, 20 million people gained insurance through this legislation. In the US, there are 1.8 million new cancer diagnoses every year, and cancer is considered to be a healthcare amenable condition where access to healthcare is expected to improve outcomes like survival. To that end, we wanted to ask, was there an additional cancer mortality benefit for states that expanded Medicaid under the Affordable Care Act compared to those that did not? Next slide. Using a comprehensive database maintained by the CDC, which captures all cancer deaths for all US residents, we grouped states by Medicaid expansion status as of January 1, 2015, resulting in 27 states plus the District of Columbia in the expanded group and 23 states in the non-expanded group, which you can see illustrated on this map. We analyzed age-adjusted cancer mortality to control for the effects of differences in population age distributions and established trends from 1999 to 2017. We then did further analysis looking just at the years leading up to 2014 and right after 2014 when most states chose to adopt Medicaid expansion. Next slide. We found that cancer mortality improved over time from 1999 to 2017 for everyone, which is represented by the solid black line on the graph, and that age-adjusted cancer mortality was consistently worse in non-expanded states, represented by the solid red line, when compared to expanded states, as shown by the dotted blue line. The gray bars on the graph represent the peri-ACA years that were specifically evaluated in the difference in differences analysis. As these overall trends show, the difference in differences analysis is important in this type of study because there were already large disparities between the two groups before the ACA was rolled out. Next slide. In our difference in differences analysis of the peri-ACA years, we evaluated the overall population and specific populations including Blacks, Whites, and Hispanics. This is shown in the table on the right. Overall, when we compared the change in mortality before and after the ACA, we found a greater change in the expansion states than the non-expansion states, and the overall difference was 0.5 per 100,000 people. This encapsulates the potential true benefit of Medicaid expansion on a population level. Upon closer look of subpopulations represented by the graph on the left, with expanded states being the dotted lines and non-expanded states being the solid lines, you can already see that there are large disparities in cancer mortality rates between Black, White, and Hispanic populations, with Black patients having absolute highest overall cancer mortality. Specifically, in the Black population, you can see that the overall cancer mortality rate was improving at a greater rate than with Whites and Hispanics. And this may be why we were unable to find a differential benefit from Medicaid expansion in this population. Interestingly, although the graph is unimpressive in the Hispanic group, we found the greatest differential cancer mortality benefit in this population at 2.1 per 100,000 people. Next slide. In conclusion, this is a first study to show a directly measured cancer survival benefit from Medicaid expansion. We found that cancer mortality decreased over time across all populations, with additional benefit in states that expanded Medicaid after 2014, which translated into an estimated 785 less cancer deaths in 2017. It is estimated that an additional 589 cancer deaths could have been prevented if non-expanded states had expanded Medicaid. Of the subpopulations assessed, Hispanic patients seem to reap the most benefit with the greatest additional mortality decrease. However, there was significant baseline variability in survival, which may reflect known poor access to healthcare in this population. Black patients did not appear to reap the same mortality decrease, although this may be due to continued large mortality gains over time. Further study is needed to understand how national programs and policies, such as the Affordable Care Act, can continue to improve access to care and decrease healthcare disparities. Thank you.